She's our new USD World President, and now we will hear some very practical issues she wants to address. So, Charlotte, please.
Thank you. So, thank you for staying for this next short session. I'm going to talk just a little bit about PID and syndromic management like we do in the United States for mycoplasma. So these are my disclosures. And so I'm going to just describe mycoplasma in relationship to PID, and this is from Lisa Manhart's work, and then talk about diagnosis and mainly demonstrate that PID treatment, as we do it in the United States, does not eliminate mycoplasma. So, pelvic inflammatory disease is very common in women in reproductive age, and has significant age and racial or ethnic disparities. Potential long-term sequelae include ectopic pregnancy, terminal infertility, and chronic pelvic pain. So we know that future fertility is important, as well as prevention of chronic pelvic pain. Adolescents with PID are particularly at risk. We have shifted in the United States from inpatient management of PID to outpatient management of PID. And so patient adherence to treatment in young adolescents is less than optimal. And adherence is very complicated. So we know from Taylor Robinson and Jorgen Jensen that we have a lot of associations in women and men with chlamydia, with mycoplasma. We see about a twofold increased risk. We also, all of the reproductive outcomes like cervicitis and endometritis and preterm delivery and abortion and infertility, but of note, there's about an overall twofold increased risk for acquiring HIV. So about twofold for PID. So this slide is from Liz and Dr. Manhart's group, showing that looking at many studies in the literature, we can come up again with an increased odds ratio looking at about 2 or 2.1 for PID and mycoplasma. So there's a lot of plausibility for the pathology. For cervicitis, we know that we get chronic inflammatory cytokine increased secretions. We get increased responsiveness to secondary PLR stimulation, and even low burdens of the organisms is capable of eliciting chronic inflammation. For PID, we know that in fallopian tube cell cultures in vitro, you get morphologic changes in the ciliated cells. You get salpingitis produced in monkey models. And you can actually show that it ascends from the lower tract to the upper tract in mouse models. And then we also detect it in the actual fallopian tubes and tissues in women with salpingitis. So, as you've heard before, culture's insensitive. We have PCRs and NATs. Most of the ones are research. We have quite a few that are cleared for CE mark, but none of the diagnostic assays are cleared in the United States. We do have 2 potential FDA trials coming up, and that's with the hologic assay using the transcription-mediated amplification assay, and also SpeedDX in Australia, looking at what they call the resistance plus mycoplasma assay, which not only diagnoses mycoplasma, but at the same time tells you if there's a resistant mutation that is present. So I went over this earlier for those of you who were here, but basically the SpeedDX is a new assay. It's a new kind of amplification with qPCR, and it uses 3 different sections, a primer, anchored 5T tail, which is matched to 2 an insertion and a mutation M, and then during amplification, the insertion gets amplified, the insertion sequence gets amplified with the amplicons and then detected using plexzymes. These plex will bind and cleave a reporter probe, which then can give you a fluorophore, shown there in the green. So this is about a little study that we have been looking at, yet unpublished. There's a longer presentation, which I think is either went on a few minutes ago or should be going on at the present time, of the whole study. But in just looking at what we see with diagnosis with organisms that are associated with the baseline visit of these adolescent girls with PID. So 259 girls are admitted at baseline with PID, diagnosed either in the emergency department or in the adolescent medicine clinic. And they get a baseline diagnostic assay for chlamydia, gonorrhea, trichomonas, and mycoplasma. And our question is, does treating these girls with the CDC in the United States recommended treatment for PID have any effect on mycoplasma? So at baseline, you can see we had a 25% prevalence of CT and 8% prevalence of gonorrhea, 16% prevalence of trich, and a 19% prevalence of mycoplasma. These girls are highly non-compliant in general, and so this TechN study, as it's called, and you can look up the abstract for the full study in the book, but basically they're non-compliant in general because they're being treated as outpatients. So the study is to be in close contact with them with some sort of technical way, like a cell phone, and making sure that they are adherent and taking their drugs. And even though there's close contact with a nurse who's calling them up and having them come back, a lot of them don't complete their drugs that they were given when they were diagnosed. But anyway, they are followed up at 30 days, and Dr. Trent has like about a 94% follow-up rate. These nurses actually go into the home and interview the girls and get their samples for their 30-day follow-up and their 90-day follow-up. So at the 30-day follow-up, CT and G combined was 8%, 6%. So the CT and the NG are coming down. We don't know if there's some reinfection or lack of clearance, but they are coming down. However, you can see that at the 30-day follow-up, the MG prevalence stayed up. And at the 90-day prevalence, MG prevalence stayed up. And so we really don't think that, excuse me, that the recommended CDC treatment for treating mycoplasma in PID is accomplishing what we think it should. So this has been talked about all day today, that we see that these resistant mechanisms are in the 23S gene of the ribosomal RNA, and now we're getting resistance to moxifloxacin in the JAR-A and the PAR-C. It's very interesting that the PAR-C is more prevalent with the mutations, whereas looking at the same two JAR-A and PAR-C mutations in gonorrhea in the United States, you hardly ever see PAR-C without seeing JAR-A. And so JAR-A seems to be the most commonly seen with gonorrhea. But I thought it was very interesting to hear today that PAR-C seems to be very common. So these are two studies that are unpublished today looking at resistance. The multiplex assay by SpeedDX looks at the prevalence in this one study, 83%, and 56% of them were resistant. This is the Tbilisi study. The retrospective study and that we presented here, and the prospective biohealth study that we presented here, both of these in abstract form. We found a percentage of resistance of 36 and 56%. Sequencing that is done in a Gatling study using a multi-center cohort in the United States. The prevalence was 16% in females, 17% in males, with high resistance rates of 50 and 42%. And then Dr. Chernesky, Max Chernesky in Canada, has just had a paper published looking at using the urinary meatal swabs and detecting more mycoplasma than urine in men. His prevalence was 15%, with 55% being resistant to the macrolides. So, in conclusion, mycoplasma seems to be difficult to detect, and we have no FDA-cleared assays in the United States, but we have 16 assays that are also able to be accessed by people who live in Europe that are CE marked. We have many strains, high percentages, 50%, up to 50%, showing that there are resistant mutations. We see that recommended treatment for PID in adolescents doesn't really seem to decrease the mycoplasma prevalence. There are no, I think, prospective studies that looked at treatment and resistance for looking at PID in women, and these studies need to be done. And we need also more other types of studies to see whether or not the precise treatment of MG at baseline when someone's diagnosed with PID, whether or not they effectively eliminate mycoplasma. So that's all I have.